do primarily interventional pain management, and we're going to talk about some of the treatments that I offer that Boston Scientific helps support that I think we've had a lot of success with over the past couple of years, and try and get people educated about some things that are out there that maybe we haven't tried before. So first thing we'll talk about is some different options. We'll see if any of these options apply to any individual cases, and then we'll talk about some things to bring up at your next visit, either with me or another doctor. First, I think there's a lot of misconception about when should you see a pain doctor? And really, most pain management doctors treat predominantly chronic pain. We will treat acute pain, but by and large, we treat what's called chronic pain. And the cutoff there is around about 6 months of painful symptoms. Obviously, if there's ever anything you're worried about, make an appointment with a physician. But 6 months is kind of the tried and true cutoff for chronic pain versus acute pain. And once you cross that 6 month mark, things have kind of morphed from this acute inflammatory process into a more day-to-day limiting activity. So about the 6 month mark is generally when we cross that threshold into chronic pain. We want to start being more aggressive before we kind of cement those neural pathways that trigger some of the painful responses. And so further diving into that, there's really two primary groups of pain or painful stimuli that we associate with. The first is mechanical pain. So this is joint pain. My knee hurts when I walk around, or hip pain. And this is what a lot of people are familiar with. These are the aches and pains, the pain after soft tissue injuries. And if you're unlucky, sometimes you'll also have nerve pain that can come on either at the same time or in a delayed fashion. And nerve pain tends to be this more burning, stinging, this vague sensation of discomfort, as opposed to mechanical pain, which you can usually put a finger on and say, I hurt right here. Nerve pain is a little more vague and tends to be a little more widespread. Next. And so, the big question is when should you seek treatment for chronic pain? And really the big question to ask is, does my pain limit me? And that's the fundamental question that we want to answer and what helps shape our goals. So if pain is more of an annoyance, it's there, doesn't really interfere, able to go about our activities of daily living, do the things we enjoy. Well, it's annoying, and we should still try to mitigate that as best we can. But once we cross from that annoyance into that, well, now I'm avoiding activities. I don't want to spend time with my kids or my grandkids or my spouse. I don't want to do my hobbies. I don't want to play golf. I don't want to go dancing. These sorts of things. That's when it really has the biggest impact on your life, and that's when you absolutely want to see somebody and start working to essentially regain function, regain your life. So there's a lot of different ways and different approaches to treating both acute and chronic pain. I generally approach pain as a pyramid or a ladder, and at the very bottom you have what's called conservative care, which most people by the time you're seeing me or another pain management physician is things like physical therapy, chiropractic, home exercise, massage therapy, these direct manipulation pathways, and they are quite successful for a lot of folks. Like everything else, there's a failure rate, and after that we start moving into oral treatments, so different medication options, some of varying success rates, and then we start getting into more advanced things, up as far as surgery. Some folks with back pain wind up getting back surgery, and sometimes that's not even enough. So what else can we try? So the two big things I'm going to focus on today are radiofrequency ablation and spinal cord stimulation. Both use electricity to help try and treat pain. They use it in very, very different ways. They both treat nerve pain, and they also treat mechanical pain to varying degrees. So first we'll talk about RFA. That's probably what more people are familiar with. That's a lot more common than spinal cord stimulation. But essentially, radiofrequency ablation involves using a specialized needle or probe and targeting certain areas of the body, generally the sensory nerves that actually tell our brain that we're having pain, and we burn them or we ablate them. And it uses electricity, similar to how a microwave heats up your food, actually heats up those little nerve endings and and causes those nerve endings to die off. Most of my patients are going to be talking about this as a nerve burning. That's actually a misnomer. What we're actually doing is causing an injury to that nerve, which causes it to kind of degenerate or waste away. Unfortunately, radiofrequency ablation is not permanent. Generally, those little nerve endings will grow back over time. But the good news is, generally speaking, you can repeat radiofrequency ablation as long as it retains efficacy, and it generally doesn't lose a lot of efficacy over time. And the success rates are actually really good. So from the get-go, if you look at all comers, haven't done any diagnostics, it's about 80% of folks. So 4 out of 5 folks with some sort of chronic pain in areas we target for radiofrequency ablation can get some relief. And then vast majority, 91% of people nationwide are happy they went ahead with the procedures. Generally, we say this lasts somewhere in the neighborhood of 12 to 24 months. Most studies look at 2-year data. And at 2 years, most folks are talking about repeating their ablation if they haven't already. So that's pretty much it for radiofrequency ablation. Pretty straightforward, pretty simple. I think most people here that I've seen, we've talked about this at least once. Spinal cord stimulation, I think, is kind of the meat and potatoes we'll spend the rest of the time talking about. So SCS, been around for a really long time. We first started doing this in the 1970s, about 50 years ago, so way before I was a doctor. And it's come a long way since then. So I kind of equate the technology to cell phone technology. When we look at what cell phones looked like even 20 years ago, 10 years ago, year over year, the devices do more, they're better at what they do, and they expand their portfolio. So the original indication for spinal cord stimulation was essentially you've done everything under the sun to try and treat your low back pain and only your low back pain. You had surgery, maybe 3 or 4 surgeries, and it was the 1970s, so those surgeries weren't as good as they are now, and you still hurt, so somebody thought, let's put a battery pack and some wires in your spine. And it turns out it actually really helped. And that kind of spurred a lot of innovation and a lot more research into why it works. And fast forward to 2025, the portfolio for which what we use spinal cord stimulation to treat has also expanded rather rapidly. So while it used to be just what we call post-surgical or failed back surgery syndrome back pain, now we're treating radicular pain, so pain that goes down the leg, goes down the arm, neck pain, low back pain, still a big one, even post-cancer pain, diabetic neuropathy, and each year we're adding more and more indications and kind of expanding the portfolio, because at the end of the day, we're treating the highway that pain takes up to the brain where we interpret it, and so it generally doesn't necessarily matter why we hurt, we're able to treat it. Spinal cord stimulation is a good catch-all for many painful syndromes. Who's a good candidate for SCS? Well, generally you have to be diagnosed with some chronic pain syndromes. That generally means you've had 6 months or more of pain. Depends on what insurance company you have. Medicare is the least restrictive. Obviously, some of the commercial payers have more restrictions, more guidelines they add on this. But the long story short is the insurance shouldn't be what holds us back from trying treatments. It's my job or your pain doctor's job to figure out how to get things approved for patients. And anybody with pain over 6 months duration, it's not unreasonable to have this conversation with your doctor. Are you a candidate? Is this something that might help you? Is it worth trying? The modern devices, you control the cell phone. When I trained with spinal cord stimulation, we were just starting to give patients some control over their devices. Now patients get a lot of control. They get multiple programs. You can tell the device, what's working, what's not, and it makes changes in real time. This is a big deal. It used to be you had to come see your doctor, have a reprogramming session, make changes, wait a few weeks, come back, and it was this iterative process. Now you can do it all from your phone, and it works pretty well. So first part of a spinal cord stimulator is we do a trial, and it's pretty similar to an injection, like a steroid injection in the back, except instead of injecting a medication, we're actually injecting some wires. And those wires are actually going to be taped to an external battery pack, usually taped to the hip, and you go home that way. And you test this thing out for about a week on average, depending on what we're trying to treat. And we make adjustments in real time during that week. At the end of the week, the wires come out and there's nothing left in your spine. So it's a true, nothing's put in on a permanent basis test. And if it works, well great. We have a conversation about what the next steps are, how to get you some more permanent pain control. If it doesn't work, obviously it's sort of a no harm, no foul type situation. There's not a metal box in it that's not doing anything. And there's lots of patient testimonials on the Boston Scientific websites. And if y'all want to hear things from people that aren't me or aren't doctors, I think it's very useful to go to the Boston Scientific website and watch some of these. And so just further expanding again, as the technology gets better and better. It used to be that spinal cord stimulation was a one-size-fits-all. And we basically turned it on, and it made your legs tingle, and the tingling masked the pain, but you were left with this kind of buzzing sensation, like you were driving down a bumpy road on a motorcycle. And many people really didn't like that. It was almost worse than having pain. It was almost more limiting. Now, most devices can be set to be what we call sub-therapeutic. So it's on, it's working, you don't feel a thing. We can still make your legs tingle if you really want. Most people don't like that feeling, but it can be set that way. And some people are really reassured by feeling, oh, I know it's working. I like to have that buzzing, but don't have to. That's kind of the old style technology that makes you feel the buzzing. Now it's just an added bonus if you really want it. Most people don't. And so what's the science look like? Well. There's a lot of studies that have gone into spinal cord stimulation, and unfortunately, some of the older studies aren't as good as the newer studies, and that makes sense. When we look at this from a technology standpoint, well, if I asked you, well, what was your call quality like on your cell phone 20 years ago? Well, it may not have been great, except in certain instances. You lived out in the country, reception sucks. Well, now, more and more studies are coming out with the newer devices showing really good responder rates. So we see upwards of 80% of folks that undergo a spinal cord stimulation trial get really good relief. We're seeing upper to mid 80 percentiles of patients that say, yeah, I'm really glad I did this. And with some of the new technology, it's almost instantaneous. As soon as we turn the device on, you're getting relief within minutes, as opposed to used to be weeks, days or hours after we made a change before we knew if it was helping. We know in real time. Next. And so one of the biggest new indications for spinal cord stimulation that the FDA recently gave approval is diabetic peripheral neuropathy. This is something that's not new to those of us that have put spinal cord stimulators in, like myself, but we had to do it on kind of an off-label basis, meaning we knew it worked and we could get it approved, but it was difficult because it wasn't specifically indicated for this problem. Well, recently the FDA looked at large studies and said, hey, this actually really helps folks who have diabetes, who have painful neuropathy from their diabetes. The takeaway from this is it also works for other causes of peripheral neuropathy. So chemotherapy-induced neuropathy, small fiber neuropathy, even idiopathic neuropathy helps. And not only does it help take away their painful symptoms, it actually shows some remodeling of those small nerves that get damaged with these disease processes. And we actually see some functional recovery in some patients. So not only does it help pain, it actually helps recovery, helps reduce injury, because if you have a numb foot, step on a nail, hurt yourself, you don't know it, becomes a much bigger problem than it needs to be. This helps reverse a lot of that. Next. And so, DPN or diabetic neuropathy, most patients have kind of been largely ignored by this. It's something that's historically been managed by primary care doctors because there weren't good treatments for it. And generally, you got sent to physical therapy, which didn't help because it's not a mechanical problem. You try things like a TENS unit, one of those foot vibration machines. All these are designed to kind of desensitize the nerves. And the issue is you're treating the nerve itself that's damaged. You can't regenerate it at the source. You have to go further up the spinal canal to kind of promote regeneration. So most of these therapies weren't very effective. The responder rates are lower 20 percentile for a lot of these treatments. They just didn't work. Patients were frustrated and a lot of them gave up. Now, this is really excellent treatment with good response rates. And so real world evidence, it's actually better with diabetic peripheral neuropathy than even other causes of low back pain. Success rates about 80%, but overall satisfaction rates 95%. So it means only 1 in 20 patients regret having tried this. That's really good. To put that in perspective, folks that get knee replacements, it's about 1 in 3 patients regret getting their knee replaced. 1 in 20 regret getting a spinal cord stimulator. That's a big difference. And so, let's say, we meet, we talk, we're getting ready to do a spinal cord stimulator trial or permanent implant. Well, few things that patients need to do is basically we need you as healthy as you can. Anytime we're doing anything, everything comes with risk. The better controlled things like blood glucose, blood sugar are prior to any major procedure, the better patients tend to do. So a big hallmark of treating any kind of pain, particularly peripheral neuropathy, is getting you medically optimized as best we can. And in general, most patients we're treating alongside their primary care doctors. So what's next? So Boston Scientific actually owns the website pain.com. That's where there's a lot of patient testimonials for both spinal cord stimulation, radiofrequency ablation, and a myriad of other surgical procedures that a neurosurgeon or spine surgeon would do. My name's on there. I hope. I think it has been for quite a while. But if basically if you've had pain for more than 6 months and things aren't working or it's interfering with your life, you just talk to somebody. And whether it's me, whether it's somebody else, doesn't matter. Talk to somebody. See if you can regain some function and enjoy your life.